I was thinking today, poor Elsa, she's referred to, and hasn't she done a wonderful job, by the way, organising us all and emceeing? It's absolutely wonderful. It's what she does for us every day. Quite amazing. But I thought, oh, poor Elsa has said that I'm going to talk about safety planning, and I am going to talk about safety planning. I will get there, I promise. Just a couple of things I wanted to say before I got there. Like everyone, how many talks do we go to in our lives where you want to go for one specific aspect, like treatment? Give me the gems, give me the gold. And then the speaker runs out of time, just as... So I promise I will try not to do that. Just going back to Anthony Pisani's framework, and in particular the risk formulation. Without a formulation, which in psychiatry is part of our training, it's always been a fundamental part of our training. We get examined on it. We're expected to refine it over the years, which we do. We're forever learning in our formulations to assist with our diagnoses and, of course, our management. But with respect to suicide, I think that the Pisani risk formulation is actually extremely helpful, and it incorporates factors, aspects of history taking and information collection that we've all done, but it puts it together, as he says, in a nice framework that's meaningful, that we can then progress to use the information in a productive, helpful way to be able to plan specifically for the individual. So that we collect the clinical data on the left there, and in the handout there are copies of these diagrams. So I apologise, they're very difficult to translate onto slides and are a little bit blurred. Clinical data, which then feeds into what we need to devise the risk formulation. So as I mentioned before, we're going from predictive to preventive. It's anchored in the clinical context, and we need to remember that the rates of suicide differ across our community, and they differ within certain settings of the community. So a patient or an individual are considered high risk in one context. So, for example, a child sent to a school counsellor may be considered low risk in another context, for example, the inpatient mental health unit. And you see that this a lot in health services. We receive referrals, and sometimes, unfortunately, we think, oh, this person doesn't need to be in the emergency department. But we forget that that individual has come from a context where that context may not be equipped. And if they are equipped, they may be too busy and not expecting this crisis within that context, for example, a school. So we have to keep in mind that we're all part of the fabric, and we all work together, and we mustn't, we have to be mindful that everybody is doing their best for the individual at any given point in time. And we have to remember that each setting has different resources available for intervention. The purpose of the assessment also varies by setting, where the individual turns up, where they begin the journey. And we have to conceptualise and describe risk in relative terms rather than the categories I talked about before. And by relative, I mean, is the individual at a lower or higher risk relative to other people in the same context at that time? A risk formulation endeavours to capture the fluid nature of suicide risk, and I think that's one of the important challenges about working in suicide prevention. Suicidal ideation, suicide plans, suicidal behaviour, they're not static. They're forever changing, fluctuating and being modified by, as I spoke about earlier, life events and the environment, internal factors for the individual and external factors. Something we try and address is how the person's current risk compares to risk in their own risk in the past and how their risk might change in response to future events. We try and identify the person's immediate distress and what resources are available to them at that cross-sectional point in time that we can identify. We also try and identify intervention strategies. So what may our service be able to offer? What may be available in the community? With the risk formulation, our goal is not to predict behaviour, but to try and promote communication and collaboration amongst all of us with regard to that individual, as well as their family, their loved ones and their caregivers, in an attempt to reduce risk in the short and longer term. So back to the clinical data, there are two groups of factors and each comprise 4 aspects. So in any given individual, there are going to be enduring factors, so long-term factors, the individual's strength, their protective factors that they've carried around for most of their usually adult life and during their formative child and adolescent years. We're looking for long-term risk factors. Obviously that's where trauma, early childhood, negative early childhood adverse events play a significant role. We're looking at the person's temperament and personality, their tendency to impulsivity, their ability to master self-control, and very importantly, their use of substances, alcohol, other drugs, and prescription medications. Do they have a history of taking prescription medications safely, reliably? Have there been issues with prescription medication in the past? And obviously their past suicidal behaviour. We know that past behaviour is the most important risk factor for future suicidal behaviour and death by suicide. Then there are the group of more dynamic factors, and they include any recent events, any recent relevant events for that individual. What level is their suicidal ideation when we're seeing them? And have they a history of suicidal behaviour or self-harming behaviour? Are they currently engaging in self-harming behaviour? What are their current life stressors? What's impacting on the individual at the moment? What's important in their lives cross-sectionally at the moment? And are there any direct precipitants prior to them seeing us or us interviewing them and assessing them? What's led up to the crisis that they may be in at the moment? What are their current symptoms? Are their symptoms consistent with a mental illness? Are their symptoms consistent with a major depressive episode, a hypomanic or manic episode, or a psychotic episode? What's their level of suffering? How are the symptoms impacting on their quality of life, their level of functioning? What recent changes have happened in their lives? And to what extent are they willing to engage? Are they asking for help? Are they there with us because they're under duress from other people? Or have they self-presented willingly, asking for help? And any relevant history on previous engagement with health services is also helpful in terms of predicting how likely the person might be to comply with services we put in place or resources we may refer to. So the data we collect from all those categories, we try and synthesise into 4 distinct judgments to inform our management plan. And the 4 judgments include risk status. So that is the patient's risk relative to a specific subpopulation. Risk state, which is their risk compared to their own baseline or a specific time point in their lives to date. What resources are available to this individual at the moment that we can identify, and they might be able to identify, or their carers might be able to identify. And this is the one that I mentioned earlier today, the foreseeable changes. Changes in the individual's life may be able to be predicted, but I think very importantly, a large number of them we're not able to predict. And these changes may quickly change the patient's level of risk, and we need to be mindful about that. So what I was hoping to do is present two cases today, use one case to illustrate how we put together a risk formulation, and a second case to illustrate safety planning. There may be people in the room who might be familiar with these individuals. I have tried to de-identify them as much as possible, and hopefully the information, if you do recognise them, is helpful and not harmful. I'll begin with Edward, who's a 37-year-old man. Oh, and by the way, copies of these cases are in all the handouts, the clinical information. Edward presented to the emergency department, to the triage desk. He's a married man who lived with his wife and 3 children aged 9, 7 and 18 months. He was employed full-time as a tradesman. Immediately my radar is saying higher level of functioning, employed full-time. He presented stating he felt paranoid, anxious and low in mood. When we were able to see Edward, he complained of a deterioration in his general health, in his well-being. He described his anxiety levels as having increased severely in the recent days to weeks. He described a previous history of intermittent panic attacks. The interesting features about him, when he described his beliefs, he believed that people at work, as well as the general public, were judging him, they were talking about him, and they were laughing behind his back. These thoughts or preoccupations had been gathering intensity and momentum, what felt like days to weeks, to the point that he was avoiding leaving home due to his levels of anxiety, but he was able to get to work. He didn't describe any abnormal perceptions. Importantly, what we're always listening out for in the emergency department, and all of us in health, was that he admitted to having chronic, vague, suicidal thoughts, which he hadn't acted on. When we asked him in more detail about his thoughts, he admitted that he'd considered gassing himself with motor vehicle exhaust. But he strongly denied any intent to act on these thoughts today. So sorry. He told us that the thoughts worsen with low self-esteem, low mood, and they're getting worse because as his symptoms were deteriorating, he was worried that he wasn't going to be able to work anymore and he was going to lose his job. He was also preoccupied with a worry that his wife would leave him, but he wasn't actually able to justify or give us any examples of why he had this fear. But he was certainly preoccupied with the belief. In his past history, he described numerous intermittent episodes of anxiety and the panic attacks I'd mentioned. He'd been aware of anxiety symptoms since childhood. And when he felt anxious, his sleep deteriorated, his general functioning deteriorated, he became more introverted, and he also lost appetite. His substance history was important. When we asked him about alcohol intake, he said, I have 3 drinks a day. On further exploration, what he was actually drinking were 3 long necks a day. And I mention that because I think it's important that a drink doesn't equal a drink, doesn't equal a drink. So what is one standard drink? And I think it's important to explore the details of any substance use with our patients, as I'm sure we all do. But personally, I wasn't familiar with the alcohol content of a long neck. So I quickly looked it up, and he was actually drinking 3 by 2.8 standard drinks a day, 84 grams a day. The maximum recommended amount is 20, with 2 alcohol-free days a week. So his alcohol use was significant. He'd also described cocaine use in the past and cannabis use, but denied any current use. Of note in his medical and surgical history was that he'd suffered an old work injury which had left him with chronic pain. He was currently on venlafaxine or Effexor and tapentadol or Palexia, which is a centrally acting opioid for the chronic pain condition. He had few social contacts outside the home. He had minimal outside interests. He loved the work he did. He was very invested in his trade. His wife worked part-time outside the home and was obviously very busy inside at home with 3 children. There was a family history of depression in one sibling. When we spoke with his wife, she alerted us to an event which occurred 2 years previously, in that her husband came home one day having spontaneously purchased a motorbike. I hadn't included there that he came home with a puppy dog. He arrived home with multiple tattoos, and she actually found out that he'd been using cocaine secretively. In our minds, that alerted us to the possibility of him having suffered a previous manic episode, and the suggestion of, was this person suffering from a bipolar illness? She also reported that he'd been minimising his alcohol use, and that she was finding empty bottles around the house, stuffed in between the couch pillows. She'd find little empty spirit bottles. So we immediately suspected that possibly he was minimising his alcohol use with us when he was telling his story. He'd actually asked her if they could stop at the pub on the way to the hospital, and she was fairly convinced that that was where he was going to end up after he left the emergency department. She also told us that he was currently consuming cannabis gummies. I hadn't been familiar with cannabis gummies up until that point, but they apparently are a very widely used form of cannabis, increasingly used in the community, and something that we should be aware of, and patients may minimise their use because they sort of don't consider them in that category of illicit substances or serious drug use. So it's important. I've certainly learnt a lot from that. In his mental state examination, he was a well-built, fit-looking man. The tattoos from a couple of years ago were visible. He was very cooperative, but he was hyper-vigilant and hyper-aroused. His mood was low, he was distressed, he was anxious. I've used the word crippled. He was crippled by the intrusive thoughts and fears, and these were always leading him to the option of gassing himself as a possible solution, even though he reassured us that on the day that we were seeing him, and in the short term, he was extremely unlikely to act. He believed that he wouldn't act on this, but the thoughts were there, and the plan was there, and the method that he'd considered was there. So he was preoccupied by the humiliation that he believed he was suffering in the workplace, believing that the mates were having a joke at his expense, and this fear of his wife leaving, for which there was no objective evidence. And when we spoke to his wife, she said an interesting thing. She said, look, I did mention that I might have to go to my parents' house to get a break, but I would never leave. I've never considered leaving. We've never separated. I'm not sure where that's coming from. There were no perceptual disturbances that he reported, and his cognitive assessment was not, didn't uncover any abnormalities. He had reasonably good insight. He accepted he wasn't well. He accepted he was in crisis. He accepted things were getting worse, and he was willing to accept treatment. Primarily, he wanted relief from this crippling anxiety and preoccupation and his low mood. In our differential diagnosis, strikingly, everything we considered, all the diagnoses we considered, are all associated with a significant risk of suicide. And I think that's important. So did this gentleman have a primary psychotic illness? Did he have an organic psychosis? Was he suffering from a delusional disorder? Morbid jealousy. We know that that's heightened in patients with alcohol dependence. Did he have a schizophreniform disorder? We had some evidence for bipolar disorder. We knew he had a substance use disorder. We knew he had panic disorder and a social anxiety disorder. And we also got a sense of these paranoid personality traits that dated back throughout his life. They may have been vague and mild at various times. They were certainly much more intense and crippling now. So the important things for us to do, primarily a risk formulation, put together a safety plan for him. He felt safe to go home. He wanted to go home. He wasn't at all interested in coming into hospital. He didn't want to come into hospital. He didn't think he needed to come into hospital. He actually believed that by coming to the emergency department, he would get help that wouldn't lead to a hospital admission. I think that's important for us to remember, that sometimes people may be reluctant to present for fear that they're going to be locked away or put into hospital. Other people present desperately wanting to be in hospital. So we see a broad range, but we need to be mindful that some patients will keep themselves safe with our help and assistance and are able to go home. We obviously needed to refer him to drug and alcohol services, our community mental health teams, and make those links as quickly as possible from the point he left our care. And we also wanted to include his GP as quickly as possible, as prominently as possible, and communicate with that individual as soon as Edward left our care. We advised that obviously there were some underlying physiological etiologies that needed to be excluded and some investigations that could be recommended. And we also looked at the psychopharmacological and psychological interventions that Edward might be suitable for and that we would recommend. So the task from this case for us as a group, I thought, which would be interesting that we could do together, is to look at, in the risk formulation, to put together a risk formulation in terms of how we do it in this specific gentleman's case, looking at the enduring factors and the dynamic factors. And on the sheet in front of you, you've got both a copy of the case and this list. So I thought I'd just leave everyone just for a few minutes to think about those points and what might be relevant for this gentleman under those headings.
Do you want to roam around on that one?
by all means, if people came up with some suggestions, I'll give you a little bit of time, and then we can work through it together, because so I'll give you a few minutes. Sorry to interrupt you once again, but I also wanted to acknowledge the wonderful photography that has been provided by a local photographer. His name is Chris Dix, I believe. Is that right, Nicole? And he's taken some beautiful scenes, and I just think it's just wonderful to be mindful of the environment that we all work in. Yes, yes. Maybe if we start to work through some of these together. So when we're thinking about this gentleman, and we're thinking specifically about his strengths and protective factors, would anyone like to make any suggestions? Any table? Absolutely. His family, work, stable work, employment, being married. Absolutely. Security, yes. Yes, he was help-seeking, which for a male is, we know, challenging, isn't it? Sorry to... That probably came out the wrong way, but we know men... We know that men find it much more difficult to express their emotions and ask for help and talk about these issues publicly in a public forum with complete strangers. It's a challenge. So I've got stable employment, the length of his marriage, the fact that he's married, and his family. He has 3 children, and he was a family man. He spent a lot of time at home, and he didn't report any particular problems in the home, despite obviously 3 children and all the challenges that would involve, and the effect on, being time poor and overcommitted. Ooh. Long-term risk factors. So longer term for this gentleman. Can anyone help me? Absolutely. Thank you. So we've got, yes, so we've got substance use, long-standing, pretty entrenched, possibly dependence, secretive behaviour. So if you look at the Cage questionnaire, he's sort of scoring positively on, for alcohol dependence. So that's certainly, and as we know, patients, individuals who suffer with anxiety self-treat. We know that, self-medicate, and alcohol is so powerful. Isolation, yes, absolutely. Isolation. He's isolated. He's got these perceptions about his workmates that obviously would be interfering with his interpersonal relationships in the workplace. So the other place apart from the home where he spends the most time, he's feeling isolated and humiliated and insecure. Yeah. That's right. So again, social isolation. That's right. Sorry? Chronic pain, absolutely. Yes. Yes, family history. Absolutely. Yes, absolutely. Absolutely.
The opioid affects the mental state, because certainly Vendone and other products that cause dysphoric states at times. GPs see that.
Absolutely, and the combinations of medications, the combination of the tapentadol with the serotonin, with venlafaxine, the serotonin reuptake inhibitor, and the effects on serotonin. I think tapentadol has less of a serotonergic effect, but it still has some serotonergic effect. So the synergy of the two medications we keep at the forefront of our minds. Sorry, I talk with my hands too much.
And with tapentadol, it's not just a mu-opioid receptor agonist, it's also a noradrenergic reuptake inhibitor. So it has its own psychotropic effects way beyond, as an addiction and pain doctor, I think that those psychotropic effects are greater than the analgesic effects.
Yes, yeah, thank you. So everything we mentioned, the substance use history, anxiety, chronic pain, personality traits, that sense of that paranoid personality, we got a sense that it was long-standing. It was sort of, it'd been a pattern, a lifelong pattern, which fluctuated in intensity at times, but it's worrying. And the family history of mood disorder that was mentioned. Then the next enduring factors, impulsivity, self-control, substance use. So we've covered the substance use. We've got the opioid use, cocaine, cannabis, impulsivity, self-control. What do we think about this gentleman? He'd been able to keep himself safe till now. He didn't have a past history of self-harming behaviour. Sorry.
And again, on the alcohol subject, we've seen that number 84 grams per day, but that doesn't take into account the little bottles hidden around the place. So the history taking of alcohol consumption is, as we know, inaccurate and complicated, and his actual daily intake may well be in the order of 120 grams or 12 standard drinks, and we haven't mentioned any days missed or any days away from alcohol where he has actual withdrawal symptoms. There's a lot of exploration left to do.
Absolutely. And the challenge was going to be with this gentleman, would he engage with drug and alcohol services? Because he certainly wasn't willing at the point of time we saw him. And that was something, when I talk about the safety plans later, I won't be talking specifically about Edward, I'll be talking about another patient, but in his plan moving forward, some of the work would be that motivational interviewing. Once you've identified the use, we've identified minimisation of the quantity as you beautifully pointed out, we really want to get this person engaged with services. You know, the danger signals are going off, the alarm bells are going off. And we know that patients who harm themselves and die by suicide use substances to assist those behaviours. They're often in the background, particularly alcohol, very much in the background when somebody is self-harming. So that historical event, that episode that Edward's wife mentioned 2 years ago, we know that there's a risk of impulsivity there. Although he's been able to keep himself safe up until this point in his life, in the past, he has had the propensity to be impulsive. Whether it was as a result of a manic episode, an actual mental illness, or whether it's a part of his temperament and personality, we can't be sure. But the history is there. The alcohol use and the cannabis use. Then moving on to the more dynamic factors, the current factors, the factors that are at play at the moment in his life that might be changeable, fluctuating, coming and going. When we think about recent, current suicidal ideation and behaviour, we've got that, the thought in his mind about gassing himself. Our patients are they're very well informed. Needless to say, lethal methods, people know the difference generally between a method that is likely to be lethal and have a lethal outcome. And sometimes the ambivalence comes in around overdose. Overdose can certainly have a lethal outcome depending on the agents, the pharmacologic agents used. But fortunately, a lot of our prescription medications, I think, are becoming safer and safer and safer, so people are generally protected, but we can't count on that. We can't count on the fact that the ambulance will turn up in time, or they'll be found in time, or they'll wake up, etc. But he certainly had, talked about a lethal method, which raises our alarm bells. Current stressors or precipitants. What do people think about? I struggled with this one. I think the alcohol use, the cannabis gummies that he was minimising. So either he was minimising them because he really saw them as a lolly, not really a significant illicit drug, or was he deliberately minimising the use? But these fears of his wife possibly going to leave him and the perceived ridicule by his workmates, they're the two factors in the history that really stood out to us. And we didn't know where those two factors were going. What didn't we know about this couple? What was possibly hiding between the surface? What was the relationship? What was in the relationship history that neither of them might have been comfortable discussing? And the perceived ridicule, was that an overvalued idea? Was it was it in relation to paranoid personality? Or was it a symptom of mental illness? Was it possibly a psychotic delusion related to depression? Current symptoms, suffering, recent changes. So we've got the self-report of increasing anxiety, the low mood, these intrusive, crippling thoughts that were relentless and he couldn't obtain relief from. And we were obviously concerned about whatever current treatment he was receiving may be incomplete, because he was certainly still suffering and certainly wasn't symptom-free and certainly didn't appear to be on the trajectory of getting well or toward recovery. So something needed to be done. There needed to be intervention pharmacologically as well as psychotherapeutically. engagement and alliance is positive for this gentleman. He agreed to come. He was accompanied by his wife, and I'm sure that she had to do a lot of encouraging along the way, and she didn't let him stop at the pub, and she didn't allow a detour. She got him to the ED. But once there, he was willing to wait, which is often very challenging in that ED waiting room. He was willing to wait, and he admitted to wanting help. So they're very important.
I was just going to say the agitation, which was possibly the most concerning stage.
Absolutely, absolutely. Thank you, Andrew. And that agitation can make an enormous, that's right, enormous difference between what remains a thought and a plan to what becomes an action. Yeah. And driving the thought process, yes.
I was going to ask you too, we need to worry about his work side of things. Although it is protective to have his work being stable, but being a tradesperson, access to different means of actually like claiming the harm as well too. Is that also a consideration?
Sorry, I missed that last bit.
Because of his access to different potential harms as well too for his work, be it actually the machinery you're using, working from heights.
Yes, no, that's a very good point. And in my attempt to de-identify him, I haven't told you what sort of trade he works as. Fortunately, I mean, there would definitely be dangerous tools involved, but generally doesn't involve heights. And in his immediate environment, there aren't lethal means, fortunately. And he does work within a large organisation and within a large team. So he's not working in isolation, which is important. He's not driving during the days. He's in a stable workplace. So that's thank you. They're really important considerations. You know, what are the factors within the workplace that could spell danger and could place him at increased risk? Absolutely, thank you. That's an excellent point. We know that chronic pain is a major risk factor for self-harming behaviour, for depression. In the emergency department, it is a priority in the assessment, but it does often fall to the lower down in the priority list. And it's tempting to think this gentleman is on medication, he's stable, he wasn't reporting breakthrough pain, but it was a significant component of the history, yes. And at any point in time, were he to become unresponsive to the current treatment, or the treatment become unavailable, as so many treatments have in 2020, certain drugs becoming unavailable, that stable, controlled state could change very rapidly. Yeah, thank you. Yes, Jackie. Yes, absolutely, absolutely. And the diagnostic challenges are certainly at front of mind, and bipolar disorder was certainly at front of mind, and optimising appropriate treatment for that condition, and keeping in mind the suicidality and the suicidal risk. And trying to address that multi-pronged approach to make sure everything was addressed. And that's one of the challenges of any initial assessment for any of us, to prioritise, to collect all that information, and then to act on that information and make sure you cover all the aspects adequately and appropriately. Thank you.
Could I suggest that there's something missing in this fellow's story? We haven't asked of him what his belief system is. Does he believe that he's a meaningless bit of jelly in a scientific universe? Does he believe in the Eastern form of
absolutely. And they're extremely important points, and I think that's where the safety plan tool that I'll go on to talk about might address those sorts of issues where if in the ED our time constraints on the assessment are such that we're not getting red flags in those areas that you mentioned, and therefore we're not prioritising them, hopefully along the treatment trajectory and the care pathway, other resources and services within our teams and service and in the community can address those particular aspects. So I think it's a really important thing and part of the shared approach in managing these people. It's very difficult. We can only work with the information we're given, and we take for granted the fact that there are a lot of things patients don't wish to talk about at any given point in time. This gentleman was very stoic about those issues, those important issues that you've raised. So during his time in ED, he wanted to get out of there pretty quickly. He wasn't particularly psychologically minded, and he wasn't there believing or expecting therapy or intervention, and at that point in time wasn't willing to share those important values and belief systems. But I would hope that through his pathway and with the safety plan in place, that those things will be explored along the way. Very important. So this is by no means correct or ideal or optimal, but it's a risk formulation that I've put together with limited information, and it doesn't touch on exactly those points that you've kindly raised a moment ago, because we didn't have that information at the time. But just to familiarise us, because risk formulation was a new concept, I think, to all of us earlier this year and last year. We're sort of grappling, getting our heads around it, incorporating it as one of our tools. So forgive me if it seems a little superficial at times, but I just wanted to use the example of what a risk formulation is and how we might put one together with information we get. So Edward's risk status was higher than the general population. He came talking about having thought about suicide. But it was lower than patients we would typically admit to the inpatient ward, in that he denied current intent or plan to harm himself. And we felt reasonably safe to believe him. We didn't have any indication that he was misleading us or he had another agenda. And obviously, intuition and experience is invaluable. We can always get it wrong, but we have to use the information we get to the best of our ability and work with the patient at all times, making sure we meet their expectations so that they are prepared to continue to work with us and our service. He was under a great deal of stress. He struggled with depressed mood, anxiety, fears of his wife leaving, and he was preoccupied by his workmates' judgments, and he was drinking regularly. He suffers chronic pain, as you mentioned, very significant. Whilst he was distressed, he faced no new stressors today that we were able to identify. He's had minimal signs of and denied symptoms of alcohol dependence, although, as someone rightfully pointed out, he actually hasn't had a break from drinking. So it's not until somebody stops drinking that we can identify or is increasing drinking. But his drinking pattern or his alcohol intake was fairly stable. So we weren't able to identify dependence, but we suspected it. His home life appears stable despite his fears, and so far he'd been cooperative with the planning process. His risk status is similar to that of depressed, anxious patients managed by our outpatient service who have experienced suicidal thoughts. So when we think about what's the best fit for this gentleman, we thought our community team would be able to meet his needs following the assessment in the emergency department. His current risk state was higher than his risk state throughout the recent months, and even higher than his historical baseline. A goal for community outpatient treatment is to return to his baseline risk state. He was likely minimising the role of alcohol in his deterioration, and continued use will place him at worsening risk. So in the formulation, we're highlighting things to look out for, the flags to look out for. He's currently consuming 3 long necks a day, that we know of. He's minimising his intake. So we want everybody involved in this patient's care from here on in to be mindful of particular things relevant to this particular individual, particularly his alcohol intake and his pain status. Ed's wife and general practitioner, whom he saw regularly for pain management, are important available resources for him, and he identified both as protective and positive. However, should his wife threaten to leave him or actually leave, or pain tolerance reduces, his functional capacity may deteriorate and his risk could increase rapidly. So we're identifying what things can go wrong or change in the immediate future in this man's life to place him at higher risk. Likewise, Ed's risk state could increase rapidly if he began to contemplate suicide while under the influence of alcohol or illicit drugs, or his employment was threatened. We hope that the community team would review his safety plan and review contingency plans for each of the foreseeable changes and encourage engagement with drug and alcohol services. His diagnosis and cause of deterioration remained unclear when we were seeing him at initial assessment. Thus, monitoring of his mental state ongoing, review of treatments for depression, anxiety, possibly treatments for bipolar disorder, and monitoring access to means are priorities during his community follow-up. I mentioned at the bottom there, we're often met in the emergency department with the expectation by families and other emergency department staff who don't work in mental health. We're expected to admit a high number of patients that we see, and people often are quite amazed and quite critical when we don't suggest admission for a patient. So I just thought, I think it's important to remember that we're always looking for the least restrictive pathway to care, because that's the pathway that is likely to ensure greater compliance from our patients, greater cooperation and engagement. We want to work with them, not against them. We don't want to do something to them that's going to scare them away forever and a day subsequently. In this case, we thought it would be safe to send this patient home at this particular time, that there were enough safety measures in place, at least for the next 24 hours. We need to remember the risk of trauma on our inpatient units. So much work is done about keeping our inpatient units safe, patient-centred, care-centred, positive environments, but they can still be extremely traumatic. We can never guarantee the mix of persons in those inpatient units at any given point in time. We have limited capacity on our inpatient units, and we're not in control of when they're at full capacity, when they're at medium capacity, when they might be, when the environment might be much calmer and less stimulating. So we need to keep that in mind, that inpatient admission may be appropriate, but there are inherent risks. We also need to keep in mind the stigma and the loss of social role when patients are admitted to hospital. After discharge, they have to face their friends, face the world, and reintegrate into society. So thank goodness we have the option of inpatient admission, but community treatment, primary care provision by general practitioners is so important. Outpatient care is so vitally important to maintain patients' level of functioning and maintain their sense of being integrated in the community and society. Before I move on to safety planning, any questions? Okay, I'm sorry.
Just make a statement. I guess, you know, listening to what you've been saying is fantastic. But how often is the telephone being lifted and that communication being given, you know, directly as this person is being discharged? Because I guess we can all say that the communication's been made and this person's been given the GP's name as being one of their safety team. But often, you know, the community and the GPs don't even know if this person's been in crisis or been there. So without that, waiting for the patient to come and present that on their telephone may be quite a hindrance to them, particularly if this gentleman is coming for pain relief to discuss his Alexia script. He may not be engaging on the mental health side with his GP. He might present very differently to the GP. Particularly the GP has 5 to 10 minutes, which is
Yes,
often the case.
yes,
But if we were alerted beforehand, not just with the, and I'm not sure how you're planning to do that, maybe you're going to
yeah,
do that, but I think one thing we just don't do very well is we don't do direct communication in our healthcare network of health professional to health professional. Probably time, and it's difficult when we lift the phone, we don't actually get a person on the phone. But I feel that the care is so much better when I actually hear directly from
It's thank you for that comment. It's so pertinent and important. The way we work in the emergency department, I'll sort of give you a snapshot. So we have the privilege of a 24-hour service in our emergency departments, a 24-hour mental health service. So there's a nurse, a CNC or nurse, a registered nurse, covering a shift around the clock. At any given point in the day, that person may be working in solo, or they may be accompanied by the next person coming on the shift so that there's an overlap. They may be accompanied by the registrar who's on site in the psychiatry registrar who's on site in the ED, but after 4 o'clock is responsible for the rest of the hospital and the rest of the service. And they may, and I may be, the consultant may be available. And at Wyong we have my equivalent consultants available on various days during the week doing various shifts. What we try and do when we assess patients is work as a team. So we might start the assessment together, and sometimes we will have the good fortune of maybe 3 staff members being able to see that individual initially. After a given point in time, we branch off. We divide our roles, and whilst one person may continue to gather information in the assessment of the patient, clinical information, another one of us will run back to the office and start getting on the telephone to other health services that have had contact with the patient, so medical records department to collect historical information. EMR is a brilliant tool. Before EMR, I don't know how we ever coped. We've got access to local service contact at our fingertips now for our patients, which has saved us an enormous amount of time. So I can immediately see how many times has this patient been to see us or been engaged with the Central Coast Local Health District, and what problems did they present with, and what treatments have been given to them and offered to them, and where are they now, and who's currently involved in their care. Lots of information that the patients can't give us. And another one of us may be trying to find a space somewhere in the ED, and space is extremely challenging and precious, talking to the significant other, talking to the patient's partner, talking to the patient's carer, talking to the NDIS worker who's brought the patient in but is about to go off because their shift is ending, so they've only got 5 minutes. And so we're all busily trying to collect information and make contact. And I'm not making excuses, and sorry if it sounds like it, but depending on what time of day it is, the challenge in who we can connect with and how we can connect and how we can gather information and impart information, it is incredibly different around the clock.
No, and I hear that, and certainly we're very aware of that. We don't get access to your EMR, we don't get access
No.
to information that you have. We often don't even know this person's presented to the ED, particularly if they only went in for the day. We might get a doc fax to actually say that they presented, but we usually don't.
Yes.
So unless there's a discharge summary, we won't know.
No.
There's often not a discharge
No.
summary for these people.
That's right.
I guess I'm just putting it to you guys because this is such an amazing plan. We want to be part of it, but we may well be excluded from it if we don't actually get timely information.
Yes, yes.
But
But that-
pull that because it's just a practical thing, and I want you to get onto the safety plan. The whole point of having a safety plan is it will effectively be a communication tool that you give to the patient and the carer, and you'd hope to take it to the GP. Because realistically, even when we try and contact GP practices during the day, we can't always get through to the GP because that's one of the problems. I understand because I've got good secretarial staff who protect me as well. But so I think you have to have something to take home, and I think the safety plan says it all. Because I don't like the discharge summaries on the EMR, I have to say. I don't think they're very useful as a tool for future management. So I'm hoping that this is what we'll provide, and we're looking at inpatient units when people leave the inpatient units already being trialled at Wyong, and that will come with a list of medication charts. So that should go to the GP and could be faxed.
Is there something in addition to that though? And I think you're right. You can't get past our receptionist.
That's fine. I've got the receptionist as well. I'm not
But part of it is actually that timely information into our information about the patient, because you're relying on the patient, one, visiting you, and two, giving you this.
I think we can get these things, safety plans, faxed, for example, to GPs, even if we can't get hold of the GP, and that's a practical solution. Emailed or faxed. I mean, don't start me on email and confidentiality, but so we'll leave that to the side. But we'll probably send an email.
Through to general practice is actually secure.
Yeah, you're
So
okay.
If you guys are doing that through the same ways on the central coast,
Okay, that'll be secure because it's health department.
they
Yeah.
are all
Okay.
secure.
Okay.
And that would be perfect if it comes really quick. I mean, if it comes quickly, and so we're aware of it.
Well, if it is after hours, then you'd pick it up the following day. Yeah.
And
Okay, I'm going to get you onto the safety plan,
Yes.
only because I think you love the safety plan, because I think it's going to have a lot of the stuff you want in it.
Yeah.
Yeah.
And I think Esther Sol, who's sitting behind you, who is our manager for suicide prevention on the Central Coast, she would be the ideal person who might be able to help us figure out, whilst we're busy training our health professionals and clinicians and allied health workers around these tools and implementing them and how to use them and what they are and what they entail, communication issues between all of us and how best to do that. We're struggling with our own communication within the service. We've gone from fax machines, which we now, since the NBN has come online, we can't get them to work. So we were relying on communicating between parts of our service by fax, which we can no longer do. So we've had to quickly implement these secure email addresses. So Thank you, and we'll prioritise that point. So, safety planning intervention. Safety planning, it's meant to be a brief intervention designed to help manage suicidal crises. And it was developed by Barbara Stanley in 2012 at the Columbia University in New York. And Stanley has a team around her. Greg Brown, a lot of the literature refers to Stanley and Brown. They're the two figureheads who developed the safety plan. The safety plan has its origins in cognitive behavioural therapy. So cognitive behavioural therapy, we're all familiar with what cognitive behavioural therapy is. It's been around for many, many years, going back to Aaron Beck. It's had a very important place in management of depression, long-standing. The safety plan is a standalone intervention, and Barbara Stanley, since designing it, talks about a time frame of anywhere between 20 to 45 minutes. Now, I put 20 minutes because I knew if I put 20 to 45, the people's response would immediately be, oh my gosh, where are we going to find this time? We've barely got enough time to do what we're currently doing. How are we going to find an additional 20 to 45 minutes? I want to talk about that as we go. During the safety plan intervention, the provider, so for example, if I'm the health professional seeing the individual, imparts psychoeducation regarding suicide risk, depending on the time I have with the patient and the context I'm seeing the individual in. And importantly, the fluctuating nature of the risk. So I'm trying to introduce an intervention and give a reason immediately why I'm introducing it, because the way you're presenting today, even though you may leave today and we've come up with some solutions and some answers and made some suggestions about a change in medication, these feelings can come back. They can come back tonight, they can come back tomorrow, they can come back in a week. We need to be prepared for that fluctuating course. During the safety planning intervention, we want the individual to convey the narrative of their crisis. We want them to tell us their story in their words. What's important to them, not what's important to us. Obviously, we can ask specific questions down the track, but it's really important to get their summary or their view, their world view of what they're going through and what they're experiencing. Together, we produce a written list, a written series of points that we share with the patient devises together with us. It's not prescriptive, it's collaborative. Hopefully, obviously when we were thinking about introducing the safety plan in our service, it's a written form, and I'll show you that in a moment. It's a written 2-page form on A4 paper. How often on a busy day do we get handed pieces of paper or write something down on a piece of paper, stick it into our bag, stick it into the car glove box? Next time we need it, where's the piece of paper? It's gone. So there are inherent dangers of anything being on paper. But we have numerous options now with technology. And my suggestion is from the outset, when we're completing these paper plans, that we get the patient, who hopefully has some credit on their phone, to upload a screenshot there and then of the work that we're doing and whatever is on that piece of paper. We don't expect them necessarily to be able to find that piece of paper in a week's time. So uploading a screenshot of it, and that way they can share it with anyone that might be relevant in their lives, whether it's family, partner, therapists, general practitioner, emergency departments, anybody involved with the person. Something I'll show you in a few moments is Beyond Blue have a wonderful app that's called Beyond Now that we can all access on our phones. It's free, and it's basically a safety plan in very personable, acceptable terms, I think, for the general population of any age. Suitable for children, it might be much better accepted by, for example, the adolescent population than it is with an older person who's struggling with technology. But I think it's a fantastic, valuable tool. Within the safety plan, we're hoping to recognise warning signs and the antecedents of the suicidal thoughts and behaviours. We want to identify the person's coping strategies. What have they used in the past to cope when things have become difficult in their lives? What have they called upon in the past? What's helped in the past? Any social contacts they may have, and adaptive social settings that might be able to distract them from suicidal thoughts. Not everyone is a social animal, not everyone's on social media. Some people choose to lead quite isolated lives, so the number of social contacts open to them might be limited. Other people belong to much broader organisations and groups and communities and large extended families, so every individual is different. The safety plan endeavours to incorporate the family and the carers in the person's situation, management and journey from the outset. We're involving family and significant others. The safety plan also has instructions on how to contact, who to contact, how to contact them. And firstly, we ask the patient to make any suggestions of people who they might feel, professionals, anyone that they've come across in their lives who's been helpful in the past and who they might be able to call upon in the future. And then we offer our suggestions in addition. Obviously, we provide at the end of each safety plan the emergency service options available to the person. Very importantly, within the safety plan, we want to address access to means to keep the person safe. We want to get an idea of their environment, where they live, if they work, where they work, what's available to them that might be potentially harmful or lead to risk-taking behaviour if they had access. And we want to restrict that access and look at ways that we can do that safely and in an acceptable way to the patient. If they're not on board with this, it's not going to work. We want this safety plan to translate to multiple settings, and hopefully it will be able to translate even beyond health at some point. And we want to make sure that we're mindful of a transition of care. We're going to use this tool not only today to get the person through today and this assessment and the outcome of the assessment, but we want it to carry over to every individual provider and service provider that they will meet along their journey. And we want this to be something that can be reviewed and revised. So in Anthony Pisani's model, the safety plan appears under the respond. If you flow down, I think it's number 2, the second contingency plan, as part of respond to, once you've collected the information, you've assessed the patient, you've got your risk formulation, then you work with the patient to come up with an acceptable set of solutions and coping strategies. Barbara Stanley did in particular highlight the usefulness of this tool in an emergency setting, and I think that's important. And we incorporate, as I mentioned, so in the context where I work, we're trying to use the plan to address foreseeable changes. So once the patient leaves us, what are the possible things that will happen in their lives? What might we be able to identify? As I said before, there might be a lot of things we can't identify, but let's work on what are the possible changes and how are we going to cope with those? How are we going to address those? How are we going to get ourselves through those? Counselling on access to lethal means. If we have the opportunity to meet with carers, we want to involve them at the beginning in the safety plan. We want to initiate referrals there and then as we put together the safety plan, and we want to document in the safety plan what are the services we suggest, what services we're going to refer to, the contact details of those services, who the patient might expect will call them, and how they can contact that service if they need to before receiving a call. We want to make sure that the follow-up is structured, and we want to make sure that there's intensive outreach for somebody presenting with suicidal ideation, suicidal plans. We want to make sure that the plan is robust and protective. And we want to ensure that the path to the next point in their care is safe, is acceptable to the patient, and is clear. There's clarity about what direction are we sending them in? What can they expect next? We want them to have confidence to work with us and stick with us. Stanley has tested the safety plans in a couple of settings. One study that I'd like to highlight today is she's tested it. Her group have tested it in a population of veterans. So over in the States, they have the luxury of having military hospitals and having emergency departments purely devoted to the military. And when they looked, so what they did is they looked at military personnel presenting to a military emergency department. And they looked at 1,640 patients across 9 of these emergency departments. Roughly 1,000 of those people had received the intervention, received the safety plan intervention, and around 450 didn't receive the intervention and was used as a control group. I might also mention there that whilst we endeavour to implement this on a very broad basis and a wide basis, not every situation, not every patient encounter might be suitable to complete a safety plan. So we have to keep in mind, be on the lookout, has the patient got a safety plan? Has someone commenced a safety plan? If not, I'm going to do it. Wherever, at whatever point of the health trajectory or pathway the patient is on. So what they did is they implemented a safety plan in the emergency department and ensured that the patients had 2 phone calls as follow-up. And the phone calls monitored the patient's mental state, reviewed the patient's progress, and revised the safety plan that was done in the emergency department. And their findings, again, are very impressive. They found that 45%, a 45% reduction in suicidal behaviour over 6 months following implementation of the safety plan. That's very powerful. And the intervention patients were twice as likely to attend their next outpatient mental health visit. So the fact that they developed a tool which encouraged the patient and gave them confidence in sticking to the pathway or the journey, I think speaks volumes about the powerfulness of this tool. So in conclusion, there was a reduction in suicide behaviour and improved treatment engagement. Our mental health safety plan on the Central Coast, this is what it looks like. It's a 2-page document, and I'll take you through each of the points separately. There are 8 sections. The last section I've got there in pink: attach medication list, discharge information for patient, carer, GP, health professionals, anyone involved in the treatment. So we're hoping to use the safety plan as an information dissemination tool for for the patient's general practitioner. And if they don't have a general practitioner, other professionals, allied health professionals, wherever the patient is likely to go next, this will be going with them. So the first point addresses the current situation causing me to seek help for my depression, suicidality. So it's encouraging the patient to actually put into words, if they can, what they're experiencing. Their thoughts, their mood, what's going on in their relationships, what's the current situation, what's the current context. Secondly, warning signs that my distress or my risk may be increasing. Now, whilst this language is familiar to us as treating health professionals, this might be the first time that this individual sitting with you has heard about warning signs. So there's going to have to be a little bit of education about what a warning sign is and what we mean by warning signs. Other patients might have heard about warning signs ad infinitum, depending on where they've, how much care they've received in the past. So every individual is going to require a different level of involvement. So warning signs: feeling low, feeling hopeless, having trouble sleeping, which Phil referred to before. Those telltale signs that something isn't right, something's going wrong. Fighting with everyone, feeling like a burden, feeling like I don't belong. I'm struggling to keep up with my normal routine. The third aspect, talking about access to means. Asking the patient and asking ourselves, how can I make my environment safe? So the language we're using is coming from the first person, the patient speaking. We're trying to empower them in their care and in their sort of path to wellness. So what things can they come up with in terms of making their environment safe? And educating them that a suicidal crisis might be acute and short-lived. So things that they have in their immediate environment might be used to harm themselves at any given point in time if they suddenly feel overwhelmed by suicidal thoughts. They may act impulsively. We know that the availability of a method affects a person's choice of using that method. So it makes sense. The less methods that are available, the less opportunity. And hopefully the less methods that are available, the more time to reflect, and hopefully the more time to make contact with crisis support services. Keeping in mind the lethality of the method will affect the patient's survival. What they do, how much they use, the choice they make, very important. Asking the patient and the patient asking themselves, do they have access at the moment? Do they have access to prescription medications? How many old medications are lying around at home that you haven't... Patients don't know what to do with old medications. It's not advisable to throw them in the rubbish bin. Ideally, we're told return them to a pharmacy who has time. When a person's feeling unwell or suffers from ongoing chronic mental illness, to expect them to bundle up old medications, it sounds easy, but it's not that simple, and take them to a pharmacy. They lie around at home, they lie around in cupboards, unfortunately, and we need to be mindful of that. Access to sharps, razor blades, knives, obviously. Car keys. Cars are important methods of people coming to harm intentionally and unintentionally, motor vehicle accidents. But, we know that cars have been used by people to self-harm very, very seriously. How can I remove access or ensure safe storage? So, is it possible to put things in locked cupboards? Is it possible to put sharps away? Is it possible to create a series of steps that make it harder to access certain means when one's feeling down and unwell and vulnerable. Who else might be available to remove access to those things? And who can check that it's been done? So whilst you and I might talk about it, you and I might talk about, oh, it's a great idea to go home and clear those cupboards of the old medication, again, all the things that might happen in between now and when the patient leaves us and them actually being able to act on our plan to get rid of those medications, so many things can intervene and stop that from happening. So can we involve someone else to check that those old medications have been thrown away, returned to the pharmacy, dealt with, or the sharps, the access to sharps has been removed? Obviously, we rely on patients' honesty and self-disclosure. The safety plan isn't going to work if a patient isn't able to communicate honestly and work together. So this is assuming an intent to seek help and do the work. What will I do to begin to resolve the situation I'm in? So, for example, distraction techniques. Distraction techniques that the person can use until the thoughts pass. Examples: listen to music, take a bath or shower, go for a walk. Like Phil said, a simple walk. It doesn't have to be a mile, it doesn't have to be a marathon. I often tell patients, give yourself a goal-directed walk each day. In the days when we used to write letters and send snail mail, I used to say to patients, use mail as a way to get out of the house or unit or home, walk to the mailbox and post a letter, a goal-directed activity, and you're actually getting exercise, outdoors. You know, there's a reason for you to do it. You don't have to find internal motivation necessarily. And that's often very, very difficult. When someone's suffering with depression, low mood, feeling suicidal and in crisis, finding motivation is extremely challenging. Watch something you like on TV. I was talking to a patient the other day about cryptocurrency, which I know nothing about. But it was fascinating that they found their own fascination with cryptocurrency and exploring what's cryptocurrency as a way of distracting themselves. So they're on their smartphone all the time learning about something they knew nothing about before, and they're fascinated by. And it's actually provided a really useful distraction for them. They're interested in it. They check it every day. They've invested, I think, $4.50. It doesn't matter the amount. It's, you know, and sorry, I know it's potentially a form of gambling, and I'm not suggesting we employ that, but I'm just as an example of the patient finding something that interests them. It may not interest anybody else, but if you can find something and tap into that, it's very, very important and useful. Relaxation techniques. Some patients will have come across cognitive behavioural strategies in the past. They will have learnt about slow breathing. They will have learnt about muscle relaxation exercises. And sometimes we're fortunate in that all we need to do is reinforce those strategies. Other people, unfortunately, who haven't had that exposure, we might keep that in the back of our minds as this would be a really useful tool for this patient. Let's make sure, if we haven't got time today to teach them, let's make sure that we suggest that someone along the care pathway will be able to spend some time and teach them those strategies. Asking the patient, what are my reasons to live and what's my motivation to get better? So thinking about they've presented not because they actually want to die, but they are suffering, they are in crisis, and they're willing to ask for help and hopefully accept help. Pointing out to them, when you're suicidal, it's easy to forget the positives in life. Encouraging them. Let's think about the positives. What are the good things in your life? And at times there may be very, very few, if any, in patients' lives. Think about what's important to you and what you have to look forward to. Again, it may be really, really difficult, and sometimes we have to really dig deep. And sometimes all that somebody is confronted by are negative anniversaries that bring up negative mood, negative feelings, and very painful, traumatic, hurtful memories. So we have to try and explore, aside from those negative, painful memories, are there some good things? Are there some positives? Are there some recent life experiences or past life experiences that they've enjoyed? And help them explore that. Encourage them to write down the good things in their lives, big or small. The strategies I use to cope. The strategies will be different for all of us. And the strategies we've all used to cope with situations in the past might help us in the future. They might fail us in the future. There's no guarantee, but it's certainly a start. Something that's helped in the past, it's something familiar. It's something you've utilised. It's something that is going to be you're going to be much faster and more able to put into action when needed. So try to work with the patient to identify those strategies. Also, what's worked in the past to redirect my thinking? So when you're preoccupied, worried about, for example, your financial position or a significant anniversary that's coming up, what's worked in the past that you can distract your thinking? What can get in the way of some of those intrusive, repetitive, recurrent negative thoughts? And who in my community can I turn to for support? And that's where culture, spirituality, community comes in. Not just health professionals. When family has let us down or family is absent, when carers aren't equipped to help, who else? What are the other possibilities? What are the broader things that the patient can reach out for? And we can also alert to help this person in crisis and get them on board. Who do I feel safe with? We want the patient, if they can, to actually come up with names. We want to write it down. We want to write down how these people relate to this patient. What's their relationship? And how the person contacts them. We're trying to refresh the patient's memory and encourage them to use those contacts. Connecting with people and places that have been positive in the past and which you can trust can help and make you feel safe. Make a list of people you could phone or video chat to, FaceTime, so that you trust, so that you feel safe. You can allow them into your world. Allow them potentially, not into necessarily the full extent of the person's crisis and grief, but partially reach out. Feel safe to reach out. Finally, professional supports that I can call on. Again, the patient might be coming for help for the first time. They may or may not have a general practitioner. They may or may not have a private practitioner. Very few people do. If they do, let's note them down, let's know about them, and let's put down their contact details together. You and your family, stroke carer, are encouraged to contact the Mental Health Access Line at any time if you feel safety cannot be managed at home. Addressing your point yesterday, the Mental Health Access Line, needless to say, the lines around the state are overwhelmed. It can be very, very frustrating waiting on the end of a telephone. And we're continually trying to address how we can make services better, how we can make services more accessible. And I want you to, we share your frustrations when you're sitting on the other end of the telephone. If you're trying to refer a patient through the intake line or the access line, it can be frustrating, but it is a very, very important access point to a service. It's a 24-hour-a-day number, 7 days a week, and that's important, a little bit like emergency departments. If you need immediate support in an emergency, you, your family, carers can present to your local emergency department. We want the patient to put their name to this. We want to put our name to it. If possible, we want the patient to sign it, and we want to sign it and put a date on it. And as I mentioned before, we want to attach a current medication list so the patient leaving the ED or leaving the acute care team appointment, as they walk out the door, the next health professional can immediately access any medication changes that have been made in that appointment. They don't have to wait for the discharge summary, hopefully. We can basically attach whatever information we feel is pertinent or useful to the next healthcare professional, and that's what we'll endeavour to do. And we also want the carers and families to have that information. We want everybody on board in the patient's care. This is just a snapshot of the app I mentioned earlier. This is the Beyond Blue Beyond Now app. As I mentioned, it's free, available on Android and iPhone, and I think it's a really nice tool for people to be able to access on their phones. It's
just on that point, there is a webinar tomorrow night at 7 to 8 for health practitioners from Beyond Blue to demonstrate the app if anyone's interested.
That's fantastic. I didn't know about that. Maybe we can get exact details later on and disseminate. Thank you very, very much. It's a lovely tool. It's colourful. It's bright. It's engaging. It doesn't have that clinical, sterile feel to it. It's very, very nice. I was going to present a case now, but Elsa's coming to tell me it's lunchtime.